looks like So it looks like people are able to get in because that was always a concern that I had. And I kind of expected the timing of the session. There is no time that works well for everybody. And there may be people who said they were going to participate and have forgotten the change of the clocks this time of year, all kinds of other reasons. But Melissa will be posting this in MedHub, I believe, so that people will be able to hear the recording. My slides will be available, which people may want to access. And if you want to jot down any notes tonight, I'm just going to get started. I'm only seeing 2 names at this point. So I want to keep this a little more informal, although I expect people will be joining in. So I'm assuming the 2 people who are on, I'm just getting, are muted, no video. If you are in fact there right now, if you can just tell me what program you're in, because there are some issues that are different specialties to specialty, and I will try to tailor my presentation to what your specific needs. Also, you may be at different places. You may already have a contract in hand, or you're just starting to interview, and I can try to make this as relevant as possible. So,
hello, my name is Radiana. I'm a hematopathology fellow at UMass, and I'm currently in the process of interviewing for positions for academic hematopathologists. So I want to do diagnostic work along with teaching and research. I've been in research before that, so let me know if you need more specifics.
no, that's fine. And pathology has its own unique, the nature of the agreements, and also the fact that you're mentioning academics. So I will focus on that. And Rachel is the other name I'm seeing right now.
Yeah, hi. I'm a resident in OBGYN here, and I'm kind of just starting the process of looking at both generalist and hospitalist jobs.
In OB-GYN?
Yeah.
Okay. And Melinda?
Yeah, hi. I'm Melinda. I am a pediatrics resident, and I am looking for a job in primary care. That's also and academia, I guess.
Okay. So I'm assuming there will be some other people. I'm going to get started, and just some quick background. So Melissa explained, I was the administrative director in GME at UMass for 40 years. Hard to think I was doing that same thing for so many years, but it changed over the years. And I actually got involved in practice management curriculum, developing that for residents and fellows way back, almost when I started, when it was more helping physicians set up a practice, your billing, your bookkeeping systems. And that changed over the years to very few people go into a solo practice. Everybody's joining existing organizations. There's kind of a mix and match of whether it's just a small practice, there's much less of that, and more people going into the larger organizations. Atrius Health, which was recently bought by Optum. So names are constantly changing. And I have a particular affinity for pediatrics because I got started doing this when my husband finished a pediatrics residency at UMass and started out in solo practice, but ultimately joined a group. So I do understand I've got a very mixed audience. There are other people joining. I'm going to just 1 more minute. If anybody else wants to let me know specialties, people who've just joined. So if there are things unique to particular specialties, I can try to make sure I address that in some way. You can unmute yourselves if you want to say anything. Okay, I will just get started then. And hopefully, there. So the session was billed as evaluating, negotiating employment agreements and contracts, which is the focus. But because of the variety of different specialties represented here, there are many types of employment arrangements that vary, that tend to be more specialty specific. Primary care practice, seeing patients in an office, is going to be different than a surgical practice, is going to be different than the hospital-based pathology, radiology. Your employer could be a medical group. It could be you are employed directly by a hospital. It could be by some other type of corporate entity. But all of you are going to be looking for some sort of position. The vast majority of you, at least initially, are going to be looking for some sort of employment following residency and fellowship. So when I started doing this, working with residents and fellows, I'm on the faculty in family medicine. I was part of their practice management curriculum, but other specialties were not offering that same type of training. So I worked with some faculty in family and community medicine, and I still have an appointment and faculty in that department, but started reaching out to other specialties and other programs. And the curriculum has evolved over the years, but residents and fellows don't have a whole lot of time for this. So I know Melissa had arranged 2 sessions, one on finding jobs, interviewing for jobs, which I used to team with the UMass Memorial recruiters, and I believe Carolyn was the person who did that session. And I've continued to do sessions on employment contracts, which I've been continuing to be involved in a number of different ways. I am not a lawyer. I do not give legal advice, but I have been looking at resident contracts for employment post-residency or fellowship for many, many years. And I've seen a whole variety. I've seen a lot of changes since COVID, which I will talk about. But I think it's really important, if you're accepting a job after residency and you're looking, especially if you're looking at it as something that this could be my long-term, I'm going to stay here forever, you want to make sure that the things that are important to you are adequately addressed in that agreement. If you're doing it for a year or 2 because your significant other or partner is doing a longer training program, you're finished being pediatrics in 3 years, but they've got 5 years till finishing an orthopedics residency, you may be looking at it as temporary, but I would still suggest it's worth having a contract, having somebody look at the contract to make sure it addresses your needs. Why you put a contract in writing at all, it's a legally binding agreement to make sure that everybody involved has the same understanding of what the agreement is. It's a written record of what that agreement is, which usually everybody ignores. It gets put in a drawer. Nobody ever looks at it again unless there's a problem. And then you go back and you see what it was you actually agreed to. And even now, I'm retired from my position in GME. I still have a faculty appointment. I'm still doing some work for UMass and have a umassmed.edu email. I am very willing to look at contracts and employment agreements for residents and fellows and give my input. It's not legal advice. I will suggest every one of you use a lawyer to protect your interest, but I can certainly point out things, good, bad, potentially problematic. And my goal tonight is to talk about some of the generic things about contracts that you should be familiar with. And since I have some of the specialties listed, I know people who are doing this tonight, some things that might be unique to the different specialties. And just one last comment, and I'll pause if anybody has specific questions or concerns they want to make sure that I cover. When I started doing this, I was a little bit questioning the value to the residents. For many programs, it was the only exposure people had in terms of finding a job. But the thing that made me understand the value was one of the residents who graduated a primary care program at UMass went to work in a private practice for 2 years out of Newton Wellesley Hospital with a private physician there, and then came back to do a fellowship. And I had reviewed her contract for her for the practice she was joining. And when she came back to UMass for her fellowship, she said, I have to tell you a funny story. I was starting work there the same time as a graduate from Tufts. And we were both working side by side in the office doing the same job. And one day the office manager mixed up our paychecks. And we discovered I was getting more money than she was. And then when we started talking, we learned, I had better benefits than she did. And the simple reason was when I reviewed the contract, I pointed out some things that she could conceivably negotiate on. She went back to the physician and said, I'd really like these changes. And he agreed to everything she requested. The Tufts resident had never been advised on a contract, just signed what she was handed. And it wasn't that the doc was out to get her in any way, but simply she didn't know the questions to ask. So that's my goal. So as I get more into it, anything specific anybody would like to say that they want to make sure is addressed of your own concerns. And the easiest way, I think, if you unmute yourself and you can make your comments. Okay. I will take pauses, particularly things that tend to be more confusing, so I can clarify for people. So most residents who are going and joining in different types of practices will get some sort of an agreement in writing, and they'll be asked to sign. And that's, many of the years that I was at UMass, people would come to my office with a contract, sometimes a resident who was looking at 2 or 3 different jobs, and do you mind reading these? I did it not because it was in my job description, because I enjoyed being able to help residents. And every time I reviewed somebody's contract, I learned more about what was being offered to physicians going into practice. So I've seen contracts that are 20 pages, legalese. You almost do need an attorney to decipher some of the language. Fairly complicated ones that have financial, and I've seen things that are 2 or 3 pages in simple English that you could look at and say, yeah, I know what it says. So I just want to make sure that as you're looking at any kind of contract, you understand the things to look for, the pitfalls, the things you might want changed. I've seen some what I consider pretty horrific contracts, but I never assume that it's bad intention on the part of the physician you'd be joining. That most of these are simply designed to protect the employer, and your role is to make sure it protects you as well. So there may be things that aren't that good, and especially if they've been written by the practice's attorney. That attorney doesn't care about you, they care about the practice you're joining. People have asked, how long should a contract be? Should it be a 1 year, 3 year? It doesn't really matter, because virtually every contract is going to have some sort of, either party can terminate with 60-day notice, 90-day notice, 120-day notice. So it's a 60, 90, or 120-day guarantee. Beyond that, they don't have to keep you. They just give you notice and you're gone. And we saw a lot of that happening in the first year of COVID, when practices who had been, moving right along, things were busy, they needed to bring in another provider. But all of a sudden, if it was a surgical practice, elective surgery cases were on hold. Hospitals were filled with COVID patients. And practices were reaching back out to residents saying, I know we signed a contract with you to start July 1st. Well, here it is, May, and we just don't have the volume. We'd like to delay your contract to December. We'd like to terminate the contract. We're giving you your 60 days notice now. And that's all it is. So you do have to understand that. Other point, if you go to the trouble and expense of putting together a written contract you're going to sign, make sure everything that's important to you, even if they've discussed it, if it's not in writing, it's like the medical record. It did not happen. And one other brief story, but I think it's particularly important because it happened to 2 residents in the same program who had offers from their department to join the faculty. One of those residents came to see me a week after she signed the contract. She said, I don't know what to do. I'm really upset. I agreed to work for the department, and I didn't realize until talking to my colleague that he's going to be getting a signing bonus. And I didn't get one, even though I had discussed it with the department head. She said, I went back to the department head and he said, you're right. We did talk about it, but it must have slipped my mind. I forgot to put it in the contract, but you already signed the contract. I do not owe you a signing bonus. And she was absolutely furious and she didn't know what to do. Should she go to the department chair? Should she demand that they put the bonus? My answer was, he's right. You signed a contract that didn't promise you the bonus. You're going to have to decide what you want to do next. You can go to the chair if you wish, but if you stay in this practice and you're going to be angry and resentful and it's going to eat at you, that's not going to be healthy for you either. She came back to me a few days later. She said, I figured it out. I went back to the department head and said, the reason I didn't get the signing bonus is because I'm female and you gave it to the male physician. And of course, the department head backpedaled the whole lot and said, oh no, we'll give you your signing bonus. The point I'm trying to make here, and it really is an important message, if it's important to you, if you talked with them about it, but they neglected to put it in the contract, make sure it's in there before you sign. And then the last thing I wanted to mention here, there are differences whether you are an employee of a practice or an independent contractor, like whether the drivers for Uber or Lyft are employees or independent contractors. And that difference should be clear in whatever agreement you sign because there are going to be differences. Questions to date? Okay. So what should be in a contract? I'm going to talk about things that should be in it, things that definitely should be taken out, and what I consider the key points that if you forget most of this, you can download a copy of the presentation from MedHub, but there are a few things I've underlined in red in my slides because I think they are takeaways that are among the most important. But one thing that sounds pretty basic, you want to identify the parties of the agreement. Is it a contract with a private group that contracts with a hospital for services, or are you employed directly by a hospital? Sometimes it's one employer and that's where you're working. Sometimes there are multiple parties, and you do need to understand all of those parties to the relationship. In what I'll call the old days, probably when I got started in GME, practices in what were the hospital-based specialties, pathology, radiology, anesthesia, the physicians were most frequently employed by a medical group that contracted with a hospital. But what happens with that hospital ultimately impacts the employment. Best example in Worcester, there were two when UMass Memorial merged and then began to absorb many of the private groups. There were some specialties that didn't want to become part of the UMass Memorial Medical Group. All of the radiologists at what had been previously Worcester Memorial Hospital quit because they didn't want to work for UMass Memorial. And that was what happened to their hospital. They really didn't have a choice. There were similar pressures and decisions made with the neonatology group based at Memorial, had always been a private practice. And when pressure was put by the Department of Pediatrics, you're teaching our residents, you're taking care of our patients, you must be part of UMass Memorial Medical Group. The neonatology physicians either left Worcester entirely or went to St. Vincent. So there really is a strong impact on relationships. You want to know who they are, where you're going to be working, and that all the blanks on that agreement are filled in. Terms of employment. Initial contracts have frequently been 1 to 3 years with some sort of renewal provision. But more frequently in the last even 10 years, contracts didn't actually have an end date. They were open-ended. And that's especially true. A couple of people have expressed interest in an academic practice. If you sign an agreement, you're going to stay at UMass Memorial. it's not going to have an end date. This is the contract, but the provisions may change year to year, and it's not something necessarily that you individually will negotiate as much as the UMass Memorial Medical Group entity will negotiate with the physician specialty groups, for instance, with the chair, or it may be certain provisions that are negotiated for the entire medical group, and these are the changes that are going to be made. Your initial contract is most likely to have an annual compensation, but that may change over multiple years. So most initial contracts that I've seen for residents will guarantee a set salary. And it used to be that in subsequent years, that salary would increase by some sort of percentage. You know, you'll get a 10% pay increase the next year. That has almost entirely disappeared. And what has happened in compensation packages is you may get a guarantee in the first year, and there may even be a provision for a productivity bonus. You know, we expect you're going to generate enough revenue, we are going to pay you $200,000. But if you generate more than $250,000 of revenue, we will share that with you in some way. But ultimately, most employment agreements for physicians move almost entirely to individual productivity. So, question which I'll get back to later when I get to some of the specifics of what are you getting paid by the practice? How much are you actually earning? You can compare two job offers. One is going to pay you $200,000 right at first year, and another one will pay you $250,000 that first year. But is the one that's $250,000 going to pay you more as you are there longer? Sometimes the increases, the dependence on productivity could make that one that's paying you less initially to be the more lucrative financially. So you can't just compare starting salaries. You have to look at how the salary is going to change. And you also do want to just note how the contract will renew if there is a process that's required. An evergreen contract will automatically renew unless notification is given prior to a particular deadline for renewal. Kind of like your health insurance at UMass, you have the same health insurance from when you started your residency until the end of the academic year, but you have to, if you wanted to change your health insurance, you have to make all those changes during open enrollment from mid-April to mid-May. And if you miss that open enrollment deadline, you're stuck in the same plan. So there are some employment contracts that operate in a similar way. Duties and responsibilities of employer and employee. This is really important information for you, but it's probably one of the least clearly defined in the majority of contracts that I have reviewed for physicians. I've seen language that just says, you are going to devote all of your professional efforts to the practice of pediatrics, gastroenterology, pathology, whatever specialty for this practice. And that's all it says. But it doesn't get into specifics of what those activities are. So you need to think about what is important for you to have in writing. I underline that be sure full-time and part-time are clearly defined, because that's been an issue that's become more important in recent years for a lot of individuals, both male, female, doesn't really matter, transgender. If you're having a family that you want to work less than full-time, you want to know what full-time and part-time is, because at some point, if you want to be able to cut back your hours, what is that going to do to your compensation? And I stress that because there have been many physicians that I've seen who were paid a particular salary for full-time work, and fair enough, that was very well understood. But when they decided to cut back to part-time, they maybe were going to be in the office 2.5 days a week instead of 5 days a week, but they were expected to take full call. They were going to be the same number of hours in a call schedule. Well, that's not 50% then. That's more than 50% if you're taking full call, even if you're working fewer regular scheduled hours. So that needs to be pretty clear. And for many specialties, define how many sessions in the office or hours, how much time at the hospital, and what the call schedule might look like. Call may even be a non-issue for some of you if you're admitting patients to a hospital that are going to be followed by hospitalists, and you've got backup, some sort of system that will do triage, and you're really not going to have the same intensity of call that back in the old days you had to answer every phone call and go in and see every patient. So you need to understand what the expectations are. What other activities, especially if you are going into an academic position, what are your teaching responsibilities? How are you going to be compensated for that? If 20% of your time is teaching, you may not be generating the same amount of revenue during teaching time. If your compensation ultimately shifts to productivity, there's a problem if there's not some sort of mechanism or formula for teaching activities, for administrative responsibilities, for other kinds of research. How is that going to be? Is it going to be you get your own grants? And how, if there are other activities, you should have some reference to that in the agreement. Equipment and facilities that the practice will provide. For some specialties, there may not be a lot of detail in a primary care practice. They've got their office space, they've got the exam rooms. You want to make sure there'll be adequate exam rooms. You can't have one exam room for a physician and expect to be highly productive. You've got to have patients waiting in other exam rooms and so on. But where I've seen the equipment and facilities section of contracts being problematic have been in some of the, what I would call high cost practice setups, something like ophthalmology, dermatology, doing things like Mohs procedures. And that's actually where this first came to my attention, with a contract for one of the derm fellows who was joining a dermatology practice that wanted to add somebody with expertise in Mohs procedures and surgical procedures, and was buying all this equipment for him to join the practice. And the language in the contract actually said when he left, he would have to reimburse the practice for the equipment that they purchased on his behalf. It was like, wait a minute, what are they talking about? And I read it. I sent him to a lawyer who could really decipher the legal implications of that. And our interpretation was absolutely right. They were incurring costs for him for equipment and facilities, but they were expecting to be paid back if he decided to leave the practice. I don't know whether he ultimately negotiated that out or just decided not to take that job. Another thing that tends to be different with hospitalist type contracts tend to address the total number of covered shifts rather than, this is a full year contract. It's just full year contract. You are working 26 weeks. It's 1 week on, 1 week off, however it's structured, but it just states the number of covered shifts that they're going to do. So this is the type of things. And if you are planning to do any other medical things on the side, you want to make sure your contract actually allows for it. There may be some that would say, no, you can't have a second job anywhere else. All of the compensation that you generate for anything medical has to be paid to the practice. If you're doing moonlighting, if you're a pediatrician, but you still want to work in a NICU, you still want to have that experience, you may not possibly be allowed to get reimbursed directly for that, it goes back to the practice, and hopefully, they will channel it to you the way UMass Memorial or UMass Medical School pays your ad comp for moonlighting will show up in your medical school paycheck, not a check from UMass Memorial Medical Center. So those are the kinds of things that would be addressed in duties and responsibilities. Any questions at this point? Okay. Compensation, just the different options could be straight salary guaranteed for a length of time, a base salary plus an incentive formula. That's when you want to just, if you look at it and says, well, yeah, they're only paying me $175,000, but they've got this great incentive formula and they say I'll make another $50,000. Is it realistic? Talk to somebody in the group and say, did you really get that bonus based on productivity? There may be some other things, so they may pay you for when you become board certified, administrative and teaching responsibilities. You want to understand how that compensation will work. There can be compensation for additional productivity bonus based on your individual productivity or based on the income of the practice as a whole. Caution if it's on the practice as a whole, because you could be joining and working your tail off, but if another provider in the practice is on a 16-week maternity leave, the productivity of the practice as a whole is going to drop, even though you're working really hard. So you really ideally would want it based on your own productivity. Other part of compensation that many residents don't think about when they're just comparing those two. What's my salary going to be? What else are they paying for? And I categorize these in two ways. There's professional expenses. Are they going to pay for your license, your DEA fees, your dues and journal subscription, education allowance, other expenses, and malpractice insurance they should pay for? There are two types of malpractice insurance. Some of you may already be familiar with this. I find, when I do these presentations, typically the OB residents, the anesthesia residents, maybe some of the surgical specialties get some information about the types of coverage, but most other residents, this is relatively new. So just a quick, what you need to know about malpractice insurance. There are essentially two types. There is occurrence coverage. It's the best to have. It protects you forever as long as you had this policy at the time the incident occurred. It is also the most expensive because it is so comprehensive. Some places you cannot get occurrence coverage. It may not be available in some states. The alternative is what's called claims made coverage. The problem with claims made, it's far less expensive, so practices like to offer it, even if occurrence type might be available, just because it's less expensive for them. But it only protects you if a claim is filed while that policy is in effect. So if during residency, and you're doing a 5-year orthopedic surgery residency, if you had claims made coverage, any claim filed during your residency, no problem. You leave and 3 years later, where it's still under a statute of limitations, a claim is filed. You no longer have that policy active. Nobody's paying the premiums on it. You wouldn't be covered unless you or the practice have purchased something called tail coverage or a reporting endorsement. So at UMass Memorial provides the malpractice insurance for residents and fellows. It is what is called a modified claims made with tail, which means it's essentially the same as occurrence coverage. UMass Memorial will pay for this reporting endorsement to cover the cost of a tail. So if a suit came in 5 years from now, you would be protected. But if you go out into a variety of practice settings, not every practice is going to cover fully the cost of tail coverage. What I see most frequently, if they don't, is something like, if you stay for 1 to 3 years and you decide to leave, we'll split the cost of tail coverage 50-50. If you're, or no, if you leave 1 to 3 years, you are responsible for the full cost of tail coverage. If you're here 3 to 5 years, we will go 50-50. And if you stay in this practice for at least 5 years, we will pick up 100% of the cost of tail. That may be something some of you will want to negotiate when you get a contract. You do want to know what type of coverage. You want to know the amount. The standard amount, that figure that's been around forever, is $1 million per occurrence, $3 million aggregate. But if you're in a high-risk specialty like obstetrics, there's frequently higher levels than that. I think UMass Memorial is something like 3 million, 7 million. It may even be higher than that now across the board because it's tertiary care institution. And if there are cases, the claims and potential damages are much higher than $1 million or 3 million. So you do need to understand the type of coverage you're being offered, and in particular, whether it's occurrence, claims made, and the amounts. Questions on that or anything else as professional expenses? Okay. Fringe benefits are different than what I call professional expenses. And again, when residents and fellows often are comparing, this practice pays X, this practice pays Y, they don't think about the dollar value of fringe benefits. Fringe benefits may also be a place where you might negotiate a little bit on the financial side with a practice. Are they going to pay for your health insurance just for you or for your family? What happens if your spouse has a better health insurance program and you don't need their health insurance coverage? Can you negotiate to get a little bit more on other benefits? So you do want to consider that might give you a little room for negotiating. Do they provide life insurance? Is the practice the beneficiary, or is it going to go to your family? What kind of long-term disability insurance they might provide? Many practices provide disability insurance, but it may be a group plan. And if you ever leave that practice, then you're now on your own, you're older, maybe have a medical issue, and disability insurance could become more expensive. GME provides disability insurance for the residents on a group basis during your training, and you are eligible for individual coverage when you leave at discounted premiums and I believe guaranteed issues still, where they won't exclude you from eligibility based on pre-existing conditions. It may be worth it, even if you're joining a practice that will provide group coverage, for you to still purchase some amount of individual coverage. So if you change jobs later, things change later, you will still have that personal benefit you can carry with you. Pension plans, many residents and fellows who've not worked outside, they've gone straight from undergraduate to college to medical school to residency, haven't really thought about putting money away for a pension plan because they simply haven't had that much income that they felt they could afford to open a 401k plan or a 403b. You're finally going to be in a real job with real compensation that you should be able to do that. And many employers will match the employee contribution. So if you put 5% of your income into a 401k or 403b plan, up to, and I don't know what the current maximum is, it was at one point $20,000 a year that you could put in, that would be tax sheltered towards retirement. Your employer might match that with another, up to 20,000, or maybe they'll match half of it. But the bottom line is your employer might be contributing to your pension plan. There's just one little catch that I hadn't thought about until I learned this from one of the faculty members at UMass who had left another teaching hospital in Texas. She had decided after 4.5 years, she was going to come to UMass. She had a much better offer, was really happy, had given her notice that she was going to be leaving the institution where she was. Somebody in her department said, you realize, of course, that we have 5-year full vesting. If you leave and you haven't been here for 5 years, all of the employer contributions stay with the employer. You don't get to keep them unless you're working here till you're fully vested, till you've been here 5 years. The length of vesting time varies in every organization. Under federal law, you have to be fully vested by 10 years, but it could be spread out 10% a year for 10 years, or it could be 50% at 5 years, 100% at 10 years. So you have to understand how vesting works if you are thinking of leaving a practice. Side note, you contribute to the state retirement system. It's not exactly a pension plan, nor is it a 403B or a 401k. None of you will ever be employed by the medical school long enough for full vesting, which is 10 years. And the benefit is also a function of how long you've worked for the state and your salary during your employment. Residents and fellows are able to take their money out of the state retirement system when they leave. And Melissa will be doing exit interviews, sending information, how you can get that money back. If you took it as cash, you would owe taxes and penalty. But if you roll it into another retirement plan, like an individual retirement account, 100% of the money transfers. That's different than what I'm talking about here. This is an employer-sponsored pension plan, and you want to understand vesting. Other benefits, vacation time, separate from education. Some contracts will lump it all together. You get 3 weeks vacation and a week of ed time. Some will say, you get 3 weeks of vacation a year, and that includes any time off for continuing ed. You just want to make sure the amount of vacation time is sufficient, and how do they handle sick leave? And as I noted before, for hospitalists, there may not be additional paid leave, and that varies depending on the organization you're working for. It may be that you're just getting paid to work 26 weeks a year, and if you wanted to take a 3-week vacation, you juggle schedules with people, so it's not 1 week on, 1 week off. But it is possible in some hospitalist contracts that you don't get additional paid leave, or the paid leave may be minimal. Questions? I know one person had mentioned considering hospitalist jobs.
I have a question regarding more of like maternity leave.
Okay.
This is sort of a more specific question on an individual basis, but I'm one of the orthopedic surgery residents, and so I've actually had one child during residency, but I anticipate to have kids when I'm attending, and I just wasn't sure if there's not like a necessarily formal policy written out, at least for our department, but sometimes I think that can be like a blessing in disguise because it allows you to have a little bit more freedom to negotiate and figure out what you need to do. So I didn't know what your thoughts were on that. If that stuff is usually outlined in contracts, or if it like leaves some area.
It typically, maternity leave is not specified separately, often falls under how they treat sick leave. If you're taking a job in Massachusetts and it is a large employer like UMass Memorial Medical Group, they are subject to, any large employer is going to be subject to the Family Medical Leave Act. If you are in Massachusetts, there's the additional paid family leave, and you would be eligible for benefits if the practice didn't provide continued payment, if there's a limit to how much of your accrued sick time, and so on. I can talk to you individually if you want to reach out. I'm on the umassmed.edu email. It's easier to reach me there than on my umassmemorial.org email about specific situation. But a lot of residents are uncomfortable even addressing things like maternity leave during the contract negotiation and discussion. What you really want to see there is what they have available for leave, because at least some of that would be applicable. And the one dilemma that I also have heard many, many times over, when residents are getting an offer and they have found out, or maybe they even knew in the process, but they wanted to wait until they got an offer, and they know they're pregnant and they know they're due when they're going to be starting the job, either of negotiating a delayed start date, or if you're going to start, you know you're going to work for July, August, you're due in September or October, to be as transparent as possible when you're at the point of negotiating the contract. Once they've already made the offer, if they were to pull back that offer, they'd be subject to potential discrimination claims and so on. So I think that can be a reasonable time, but you want to be as transparent about concerns when you're finalizing a contract. If it's well, I know at some point I'm going to have another child, you don't need to go there at that time. It's more when it happens, but you do want to know the general policy to the organization. Does that help?
Yes, thank you. I appreciate it.
Okay, other things, I want to make sure I get through everything and then leave time if there are other questions. Termination, contracts have language, either party can terminate, or they can terminate with cause if you lose your license, your DEA number, your hospital privileges, not negotiable. They have either party can terminate without cause with 60, 90, 120 days notice. You want to make sure it's mutual, not that they have to give you 60 days notice, but you have to give them 4 months notice. You definitely want it at least comparable. And there may be other language in there, you know, based on patient satisfaction surveys, they could terminate you, or based on disability. Those are things that could be problematic. You may want to have looked at, addressed. And financial reasons. I started seeing that even before COVID, when practices were suddenly feeling like, I've got to let this person go because we can't afford to keep them. I have a problem with financial reasons stated in a contract, simply because if they could terminate without cause with 3 months notice, let them keep you for, give you your 3 months notice, and then just let you go without saying, oh, the practice isn't meeting financial targets or anything else. But I think practices that may have gotten burned during COVID also, because they weren't generating the revenue when they had financial obligations to their employees, had started doing that. So it's just something to be aware. If you can try to get it taken out, but you'll have to set your priorities when you negotiate. A practice that's going to involve either a partnership or a corporate buy-in, there should be a timetable. Is that going to happen after year 2? You start discussing, and by year 3, you've bought in. And what are the anticipated costs? A lot of practices, you will never become a corporate member if you're dealing with a large organization. What was in Atrius Health, Fallon Clinic once upon a time, which became Reliant, which I believe is part of the Atrius/Optum. Those are for-profit corporations. You're not going to buy in. You're going to stay an employee. But a smaller group practice, there might be a corporate buy-in. And sometimes those costs, they'll tell you, after 3 years, you can be a shareholder and it'll cost you $100,000. And they can structure it different ways. So we'll structure it's $100,000 paid over 4 years. We'll just reduce your salary by $25,000 each of those years. And at the end of 4 years, you will have completely bought in. Contracts for first job out of training are not going to get into the level of detail of what it will cost you. But if there is going to be a buy-in, you would like the contract to say, when would that happen? And can you give me a ballpark figure of what it might look like based on costs today? What some practices that do have buy-ins do is actually have a lower initial salary for your first 3 years. And then when you're ready to become a full partner, you've actually already paid that buy-in by taking a lower salary. So instead of $200,000 a year, they're only paying you 175,000, and in 3 years, you will be a full partner shareholder with no additional buy-in. You've already paid $75,000 by taking it as a pay reduction that you didn't even know. So you just want to know if it is going to happen, what will it cost, when will it happen? Some of you may have heard this, one of the highlighted in red, because it can be a deal breaker, certain clauses that get added. So to the extent you've got a contract with a lot of legalese sections in it, non-compete or restrictive covenants. That's the language that says, if you leave this practice, you cannot practice medicine within a 25-mile radius for 2 years. They will limit your future ability to stay in that area by time and location, specific location. It might include provisions for financial damages. You can go compete with us, open an office across the street, but you will owe us $150,000 because you're costing our practice that much in potential lost revenue. They are legal in many states. They are not legal in Massachusetts. They are not enforceable, but in other states, they may face some limitations around reasonableness. 10-mile radius 1 year might be considered reasonable. 50-mile radius 5 years would not be considered reasonable. Ideally, you want them taken out altogether or modified in some way. Some practices will not do that. They got burned. They don't want you to open the practice and compete, and they will keep that language in there. If you see it in a Massachusetts contract, even though it's unenforceable, get it taken out, and they shouldn't argue with that because it is not legal currently. The fact is, if that law were to change and suddenly it became legal, you could be held to it. You want to make sure, if you're going to actually have to put up with it, what the impact will be for you. I had a resident going to one area that had a very rigid restrictive clause, and he said, I'm moving to the area specifically for this practice, and if it doesn't work out, I'm not going to stay in that state, so it doesn't really matter. But he was going there single. What if he had a spouse and kids in school, the spouse had a job, and suddenly relocating again wasn't as easy as he thought it might be. So you have to think about the what ifs. Is it going to be worth having that restrictive clause? And how restrictive is it? One of the psych residents had a contract to work for a psychiatric hospital that was owned by a chain of psychiatric hospitals. And the language was she couldn't practice within I think it was a 25-mile radius of any of their hospitals. And when she pulled up a map of New Jersey and put little pins where all their hospitals were, she could not only not practice anywhere in the state of New Jersey, but metropolitan Philadelphia and metropolitan New York City. So she didn't sign the contract. So it would have been enforceable in that situation. So you do want to understand that. Non-solicitation prohibits you from bringing your patients with you, telling everybody, hey, I'm opening across the street. But patients are still legally entitled to say, hey, where did Dr. Smith go? I really liked her. I want to join her, follow her practice. And the patient can request the medical records, but it's got to be done within the parameters of what your contract says. And then the last clause that I consider a deal breaker, because we've used it, in fact, as a deal breaker for residents who wanted to do away electives at times, is a hold harmless or indemnification clause. That's language that shifts liability from your employer to you when bad things happen. It says, if there is a lawsuit, people sue everybody they think they can collect from. So they will sue you for being the physician that messed up. They will sue your employer for your employer should have known you were incompetent and they shouldn't have hired you. So if they sued you each for $1 million, A hold harmless clause is basically saying to your employer, hey, don't worry about it. I got it covered. It was my mess up. I'll take that additional $1 million liability. You don't want to do that. You don't want to take on additional liability. And by the way, malpractice insurance does not protect you from liability that you assumed voluntarily under contract. Your malpractice insurance will cover you for the suit against you, but not the suit against your employer that you've suddenly indemnified them. And when we've had residents who want to go do an elective at a particular location and their agreement with UMass Memorial includes a hold harmless clause, our lawyers have said you either take it out or the resident can't go there. So we felt very strongly about that. We, UMass Memorial, UMass Medical School lawyers, and we would not allow those electives to take place. So it's important to recognize the impact that it could have on you. And almost done, there'll be language on dispute resolution and grievance procedures, modifying the agreement, should be mutually agreed on if there are going to be changes. So final piece on this, and then I'll just say a few more things on financial, like loan repayment, other kinds of options. So you're going to get a contract. You want to evaluate the entire contract and identify. The easiest thing is things they told you verbally, like that signing bonus, but they accidentally left out of the contract. They shouldn't have any problem putting them in. Then identify the things that you would like changed or deleted entirely, like that hold harmless clause or a restrictive clause. Anything you think is going to be bad for you, you want out or changed. Prioritize your concerns. Residents don't like to go into a potential employer saying, you got to change this, get rid of this, add this, do that. They're worried they'll lose the job opportunity. Decide which ones are deal breakers. Be willing to compromise on some of the others. If you can negotiate directly with the physicians, you may have better luck. The physicians really liked you. They want you to work with them. If you're asked to negotiate with the administrator or their attorney, then you might want to have an attorney negotiate for you. There are attorneys who will review your contracts for you at a relatively low out-of-pocket cost. But if you ask them to do negotiating, they're going to charge you an hourly rate to do that. You can always say, well, my lawyer told me that I really needed to get this changed. You know, there may not be a lawyer there, but you could do your own negotiating, but it may be a little more challenging. And one other thing, just if the practice has an assignability clause, if the practice is sold or merges with another organization, your contract could be assigned to the new organization. At least you'll still have a job and the provisions will be the same until you renegotiate them. Some people don't like an assignable clause because they don't want to work for that other organization. My view of it is at least it gives you temporary job security until you figure out what it is you're going to do. People have asked, are letters of intent or offer letters legally binding? So some of you may have already interviewed, you may have gotten an offer letter, but you're still waiting. You don't have an interview yet for that dream job, or that interview is happening next week and you won't get an answer for another 3 weeks. You are getting this letter of intent that this practice really wants you to sign because they want to finish the deal. Check the wording. If it looks like a contract, all the material terms are in there, what they're paying you, how many years, basic provisions, it will be interpreted as a contract that's legally binding. If it says, this is a letter of intent subject to negotiation of a final contract, or you add language stating this is not a binding contract, it's the intention of both parties subject to mutually acceptable terms of employment, something along those lines. You can sign it and take your time negotiating while you wait for that other deal to come along. Don't sign a contract, especially one with UMass Memorial Medical Group, because the offer's there, if it's really your hope to go elsewhere. They will not take kindly in you accepting a job and then turning around and dumping them 3 months later because you got a better offer. So if you can postpone, if you can say, you know, my lawyer's out of town and won't be back for 3 weeks, I will get this back to you in a month, do a little bit of foot dragging, but you've got to be reasonable with them whether or not you're going to sign. Having said all that about letters of intent, UMass Memorial Medical Group, the letter of intent is the legally binding, specific to you, the institutional contract, and this is true of many of the academic medical centers that I have reviewed. The institutional contract is boilerplate language on the policies and procedures of the institution about leave, about professional expenses, all kinds of things. And the only thing that is subject to negotiation is the offer letter from the department. If you look at the UMass Memorial physician contract, it is the same whether you're a pediatrician, a cardiothoracic surgeon, a hematopathologist, same contract language, not subject to negotiation. It's that letter from the department chair. We are offering you a position of, and these are the provisions. That's where you do your negotiating. Questions on letters of intent or offer letters? Okay. I don't know if there's anybody listening who is going to be looking for J1 waiver jobs, which is a whole separate issue. Your best resource is the Immigration Services Office, but I do help residents. I have in the past, and I'm willing to do that still. If you have questions about finding a J1 waiver job or looking at those contracts, I've seen some of those that are pretty nasty because they take advantage of foreign nationals. One of the requirements for that J waiver is you've got to stay in that practice for 3 years. So you want to make sure it's something the contract will meet the requirements, so you'll have your J waiver and a place you'll be happy to spend 3 years. And then for those individuals, they will get an H-1B. There are separate issues also around H-1B visas. Some of that I'm available to assist you with. I think if you go to Immigration Services on the H-1B visas for employment, they will likely refer you to an immigration attorney to work with you on that. Loan forgiveness was the one last thing I wanted to talk about, because that is an opportunity for some people in looking at jobs. They will look at programs. Massachusetts has a loan repayment program, National Health Service Corps. There are a number of different programs, the military, and people who have quite a significant amount of debt have looked for those. Sometimes an employer will offer you repayment on your student loans. Maybe they'll give you $100,000 towards loan repayment as a loan, which will be forgiven over 5 years. They will forgive $20,000 a year if you stay with them for 5 years. If they're doing things like that, you just want to make sure it's structured in a way that makes sense for you. And then many of you are looking at the public service loan forgiveness programs. And there have been a number of changes and repayment being suspended and withheld for a while, and then the loan repayments coming back. The best sources of information, I think, that cover all the concerns residents and fellows have had is the AAMC website, the Association of American Medical Colleges. Their first financial information, resources, services, and tools has a lot of information on the loan forgiveness and scholarship programs, as well as the studentaid.gov site, and talks about public service loan forgiveness in particular. The forms for that are available through the GME office. Better to get them from GME because they pre-populate the school data. Your employer is the school, not the hospital. So they will work with you on that. One important point, if you are looking at public service loan forgiveness, If you've been in eligible repayment or during the time that repayment was suspended and those years count, you could be 4 years towards your loan forgiveness, working for a government agency. This is going to play into what type of job you take. If you take a job with a private practice or a for-profit organization, that time will not count for public service loan forgiveness. The good news is if you have 4 years now and you take a, for-profit, high-paying job for the next 2 years and go back to a nonprofit or a government agency again, the clock picks up at year 5. You don't have to start from the beginning, but you do need 10 years of employment by an eligible entity, including a nonprofit. Caveat, some nonprofits are changing their structure. Atrius Health was Vanguard, and a lot of UMass residents went to work for them in their various health center sites. When they restructured, they were sold to Optum, which is a for-profit. They set up some sort of corporate structure to preserve the ability of the physicians who were expecting to get public service loan forgiveness. They set up some sort of subsidiary corporation that is nonprofit, so it didn't jeopardize this for those physicians. That's not a guarantee that any other practice will do the same. So it's something you need to be aware of if you're working for a nonprofit that is talking about becoming for profit. You need to look very carefully at what the implication will be if you were counting on that public service loan forgiveness at the end of 10 years. And that's an awful lot of information. I believe Melissa's recorded this. The PowerPoint presentation is available or will be shortly on MedHub. And any of you can reach out to me directly, marilyn.leeds@umassmed.edu. And I'd be happy to respond, do a meeting with you, look at agreements. I can keep teaching as long as I see how the agreements are evolving and the environment evolves, and I can continue to feel comfortable. Once I'm out of touch with that, it will impact my ability to continue to do this. But this has always been one of my favorite things at UMass Medical School. I love doing this, and I'm happy to help any of you going forward. And I'll stay on for a little bit if anybody has any questions that they want to ask now.
That was great. Thank you so much. We really appreciate it.
And again, if you actually, I'm assuming Melissa was able to track people who attended. But if you have any comments or thoughts, or just say, yeah, I attended, and a quick question or anything, I'll make notes of it. And anything I can do, any thoughts you have, things that I didn't get to that you were really hoping, I can provide for you, and I can look at modifying this in the future. Also willing to do it for individual programs. I did a session with Child Psych last week, and have one scheduled with the psychiatry residency program. I've done these in the past with ortho, pediatrics, OB, and I'm happy to do it as part of resident conferences if there's interest in your programs. So even if you're the only one in your program who attended tonight, talk to others if they're interested. I'm happy to do that.